Good morning, everyone, and thank you very much for joining us for today's meeting of NHS Devon's Integrated Care Board meeting. We're meeting in public, and apologies for the change of venue. We had originally hoped to be meeting in Plymouth, but for technical reasons, we've had to move here to Pomona House in Torquay. But we're hoping to return to Plymouth in April as part of our commitment to be moving the board meetings around to different locations across Devon. Particularly welcome this morning to Karen Cook, who joins us as Chair of Live Well. You're very welcome, and looking forward to having chairs from across our system join us at our public meetings as part of integrated working. So very, very welcome to you, Karen. Now, just to make a note that we are quorate, but we have received some apologies from Nigel Aitchison, from Paul Renshaw, but very welcome to Mark Sowden, who's deputising. Simon Tapley has also sent his apologies, and thank you, Joe Turl, for deputising for him. And we've also had apologies from Kate Shields. Sheena Asthana is joining us now, but may have to go later on in the day. And equally, Jane Milligan, who is joining us currently remotely, will have to step out of the meeting for an hour to join a commitment to part of the Hewitt review, but then will be rejoining us in person. So we'll also later today be having a private session of the board, and at that time we'll be discussing the upcoming National Board-to-Board meeting and also the Board Assurance Framework. So just moving on to the agenda, just wondering if anyone would like to update anything on our register of conflicts of interests. Anyone have any points? No, thank you very much. And then moving on to the item on the minutes of the meeting held on the 21st of December. Does anyone have anything that they would like to comment, or can I take it that we're happy to sign off those minutes as correct? Thank you very much. That's great. So just coming on to the part of our meeting which is held around the citizen's voice. Today we're going to be looking at asylum seekers across Devon. Very pleased to be joined by Barry Coker, who is going to be giving a presentation. But first of all, what we'd like to do is set the scene, because we want to hear from an asylum seeker about their experiences of being in Devon, and that has been recorded for us. So we're going to move over to a video, and then we're going to come over to Barry to hear a presentation from Barry Coker as well. So thank you very much.
I think the situation is the Afghanistan is now very bad. My name is Kamal Nasser. I am from Kabul, Afghanistan. I'm very worried about this because my father closely working with British Army forces, and then I'm very worried about him and about my family.
People were just relieved to be here at first and were ready to just decompress. My name is Mark Jobson and I'm the head of Sea Change. One of our main roles was to register the families with local GP practices. We chose which GPs to register them with based on the size of the family and the size of the practice. Only after about 6 months did mental health issues start to come to the fore. Before that, it was around getting people immunised, making sure people saw dentists, and making sure their general medical needs were taken care of.
The first day, Mr. Mark Jobson, he is honourable person. He very kind person. He has also support me and also my family. Lots of support and some, I think, vouchers for clothes and also appointment with doctor, registered my children, register children in the school like this.
Everything that we're entitled to, they're entitled to. My name is Kay Foster and I'm a volunteer with Sea Change. I don't have any problems phoning any of the surgeries or the hospitals and having a conversation with them for appointments. It's all very well. In fact, I took one of the ladies up to the Royal Devon University Hospital last year, and she didn't speak English, so I took her up with one of the other ladies here as an interpreter and went into the GP with her. It was a women's issue, and she was due to have a male doctor. We discovered that in the car, and they have to get permission from their husbands if they are to be seen by a male doctor. So I went in and spoke to the sister on the ward, said, look, this is last minute. You may not be able to do it, but this is the situation. Is it at all possible at the 11th hour to change to a female consultant? And the sister brilliantly said, I'm going to see what I can do, and she did it, and we saw a female consultant, which was brilliant, and so that is going the extra mile. So that is care at a very high and compassion at a very high level.
I think the practice managers have really gone the extra mile in supporting the families. It's really difficult because Exmouth isn't a diverse community, so having to use interpreters, the fact that medical consultations therefore take 2 or 3 times the length that they normally would. So a family of 5, for example, having their first consultation would probably see 1 GP, 2 healthcare assistants, and that appointment might take 2 hours to conduct. So they've really engaged with that process. The frustrating things is around dental care. We've been unable to register any of the adults with dentists here in Exmouth. Through the goodwill of a local dentist, the children are seeing them at Fairfield Dental Practice, but that's just through their generosity, and we don't know how long that will continue. One of the main issues was trying to get all the organisations working together to prioritise the medical appointments. We've had banks, Department of Work and Pensions, Devon County Council, all giving the families appointments. I remember one memory of walking into a family's room and the mirror was covered in post-it notes of all the appointments that they had coming up in the next 2 weeks. You couldn't actually see the mirror. And it was important that those medical appointments were prioritised because of the cost to the NHS. All the organisations involved, from Devon County Council to the local NHS to GP practices and RD&E, have really got involved to work together to make sure that the families are supported.
It's easy to go to make appointment, take a prescription, but a little time is taken to make appointment. Normally, 10 days, 7 days, and like this, and sometimes an emergency call 999 is very emergency. Another family call it to 99. I think 20-minute came ambulance.
And what did you think about that?
It's good. It's very good. Exmouth is very beautiful town and lots of good people, reliable people. Yeah, good place.
Well, thank you very much. That was a very helpful introduction. And I'd like to come now, and I'm sorry I introduced you incorrectly. I'd like to introduce Dr. Barry Coakley, General Practitioner, and who is also the Chair of the Eastern Devon LCP. So apologies, Barry. And thank you very much. Really interested to hear your experience, because I know you've taken a very leading role in this.
Yes, good morning, everybody. I hope you can hear me. Sometimes my webcam's a bit dodgy in this room. Really pleased to be with you this morning. As Sarah said, my name is Barry Coakley. I'm a GP in Exmouth and the clinical director of our local primary care network, as well as the chair of the Primary Care Collaborative Board in East. And the chair of the Eastern LCP. So I'm really pleased to be able to come in and talk to you about the Asylum Seeker Refugee Programme and our experiences in Exmouth. We've been looking after numbers of families at our local bridging hotels in Exmouth for well over 12 months now, and it's kind of become part of our daily lives, which is quite a nice place to be, and I hope the families feel the same. So why is it important? Well, it's really important for us to share these experiences so that we can relay that experience to other parts of the system who may not have these asylum seeker hotels there, so they understand some of the issues. As things go forward and we have more people coming to our part of the world for help and assistance, it's important to kind of learn from what we've found and to address some of the challenges that we've identified as we've gone along this process. So the three key things, I think, in terms of helping these families as they arrive are, one, to welcome them, second, to orientate them, and third, to get them registered. So the welcome is all important, and if you notice, Kamal said in his video, the first thing he said about Mark is that he's an honourable person. It's that human relationship. They've arrived somewhere strange, and who is here to look after me? Who's going to help? So a welcoming face is really important in that kind of human exchange first. Sometimes we get caught up in the system process. No, let's get you into the system and all this. Actually, let's say hello, let's introduce ourselves and tell people where they are, what the town is like, what the people are like, where they can go, where they can find help for all the various things they might. The reason why that's really important is that as any delay in them being introduced to our official statutory services or support services, they may well go out looking for help from wherever they can find it, because where they have come from has been a very disordered place, and they are seeking help wherever they can find it, not understanding now the structures of the NHS, which are highly complex, giving them that quick orientation about where you go to find help, where your GP practice is, how you seek help, and who is here on hand to help you in terms of local authority help, Department of Work and Pensions. For us, we're playing a role in terms of getting them money and things like that. So that orientation is all important. In terms of getting them started in the system, getting them an NHS number is the number one priority. Nothing happens without an NHS number. And so getting that, what we learned very quickly is almost the next, kind of alongside all that welcoming, is if someone is on hand to gather the information quickly and get those registration forms into practices, that registration can happen and NHS numbers can be issued, and everything else in terms of support starts from there. So that NHS number is that key feature, and so we've now really kind of built that in as the number one thing, and Mark and his team at the hotel have a ready supply of GMS1 pads to fill out those forms quickly and get them into us so that we can get that process done. And our teams in the practice know that when these arrive, they're flagged up as things that need to be done immediately, because as soon as that is put on our computers, the NHS number is issued and people can start receiving support. In terms of what do we do then? Well, health screening is a really important thing. Depending on where these individuals have come from, they have had various access to healthcare, and certainly where there's been disruption from conflict, sometimes that whole infrastructure has failed. So a health screening is important to understand, are there any conditions that they haven't been diagnosed with or that they have and that needs ongoing treatment? So are there existing illnesses? What are their immunization status looking like? Some of them have come from very well put together communities and infrastructure in terms of healthcare, but they haven't been able to pick up any of that proof on the way through. So they haven't got immunization records, haven't got health records. And so working with them to put and build a health record from scratch for them and their children is really important. There's lots of good advice available in terms of how the immunization process should go, depending on what has happened for them so far, and we follow that quickly, and then get them set up with the immunization schedule that they may well need in terms of the basic immunizations that our young people and children have in our country, but many adults need to catch up on that as well. In addition, obviously, COVID and flu vaccinations at the right time of year is another important part as well. The other element is infectious diseases. TB is a concern in some parts of the world where they're coming from, so making sure that screening is happening for that and any treatment required is picked up. So we run that process as well, and our colleagues in our part of the system, in our DUH, were extraordinarily helpful and dynamic in setting up an outreach system to really take a lead on that, which was very helpful for us in the community. Following that, the main thing is then maintaining that offer. So not not necessarily saying, well, that's it, screening done, we're all finished, everybody's happy on with their lives. These people then settle in. What we've found is that they will initially often be just so relieved to be away from the place that they've been, or the traveling that they've had to go through is over. They're just delighted to be where they are. Once they settle in, the process they've gone through starts to dawn on them, as you can imagine. For any human being, you start processing what's happened to you, where you are now, what the future looks like for you, what it looks like for your family, and so making sure that you revisit it and have that open door to give them access, whether it's to mental health support. Some of them have come from significant conflict areas, so there's issues around trauma, things that they have witnessed, issues around significant worries for family members who they've had to leave behind. So just being really mindful about those matters, and understanding that they often don't surface immediately, they surface later on, and so be having that ability to revisit it. And that applies to physical health conditions as well. Sometimes, it's been a few months down the line when somebody comes back to us and says, "Oh yeah, I have been taking this medication for years and years and years, and I've just remembered I haven't been taking it." And you then revisit the health side as well. So that open door policy of just kind of revisiting it and making sure that they have the support they need. So that's the kind of broad outline of what we've done in general practice. I think it's important, whilst I'm kind of naturally a positive person, I'd like to think that things have gone extremely well. There are, of course, have been and continue to be challenges in how we provide support to our asylum seekers and refugees. And so I'll just outline a few of those if that's all right. One of the ongoing one is translation. There are a number of different languages, astonishing numbers of different languages, even from people from the same country. And those languages are not naturally represented in the Southwest, we found. In fact, I think when our first asylum seekers arrived, there was only one Pashto speaker in the whole of the Southwest, who suddenly found themselves to be very busy indeed. So translation is a challenge. The families will naturally gravitate to a senior member to translate for them, and they feel secure around that. But you can imagine a number of scenarios when that might not be appropriate in terms of certain types of physical health, for example, women's health. Sometimes the adolescent children, especially female adolescents, there are some issues that are just a bit delicate, and it's not appropriate to have those conversations necessarily with a senior male member of the family. And often, even if one tries, you don't really get to the root of the problem. So having that ability to get translation in is vital. And our colleagues in the ICB have worked really hard with us to get access to both in-person translation, but now in our kind of day-to-day general practice to have access through telephone consultations as well, which is extraordinarily helpful. So one of the learning processes for us is making sure that we get used to having that as a tool day to day to help these families. Another that I covered already is revisiting that offer. It's almost like another evergreen offer, a bit like the vaccinations, an evergreen offer, especially around mental health, to just keep checking back. Are you okay? Because it may be that only over time, as I've said, things will surface. One issue that I think has caught some publicity is around food. So there's been some discussions around quantities, qualities, types of food, and certainly colleagues in local authorities and the ICB have worked hard to overcome these. One of the things we found locally was just the type of food is different. The diet that they had in their native country was very different to what they were being offered here, and certainly in a hotel environment, you can imagine often when, much like ourselves, when we go to a hotel, after a while you're kind of sick of hotel food. And so it's, there's good discussion and working with the hotel kitchen. And locally they had they created some evenings where the women of the families could influence the menu and things, which was really positive. So there are ways around it, but we just need to work a bit harder to perhaps kind of preempt those things, because they're very key to people's well-being. Transport is difficult at times, so transport to appointments locally, that's often overcome in terms of patient transport for. But of course, some individuals need to go and travel for visa appointments. And so you can imagine sometimes these things take place in Cardiff or somewhere further afield, and it's not naturally easy to find a lift up to those places. So that's a bit of a challenge. And so, there's a bit more work, I think, needed from the Home Office to support our system in terms of enabling those appointments to take place, because obviously we want people to have all the checks and things that they might need to. The two final things I mentioned are unaccompanied adults, unaccompanied minors. So there are certain assessments that obviously need to be done in terms of health checks, and normally you may well have a responsible adult to be present, and the capacity to have that available for unaccompanied minors is a bit of a challenge at times. And so when you have, if you have a significant number of unaccompanied minors arriving in one group at one time, that can put on additional stress to the local system. So again, a bit of learning from that as we move forward to put services in place to deal with that. And then finally, as Mark said in the piece, dentistry. We know dentistry is an issue. It's not, that's for our citizens that have been here their whole lives, but certainly in terms of new arrivals, their dental health is vital to to them achieving a good standard of health overall, and not being able to have even initial checks is a real challenge. And as Mark said, it's only by the goodwill of one of our local dentists that the children are even having checks. So that we know that's an issue in our system, but I think when people are particularly vulnerable, it really shines a light on it. So it's definitely something that we need to focus on and either do something about ourselves or just give a very loud voice to it, to the parts of the Bailey Central system in terms of improving that access overall. That's all I have to say. I'm more than happy to take questions if anybody has anything they would like to ask.
Thank you so much for that, Barry. And I can see Judy would like to kick off with a question. Thank you.
Barry, hi, Judy Hargaden. I've learned about this issue through a talk about education, and I'd like to know whether it applies in healthcare as well. I understand that the companies that get the contracts to house the refugees and asylum seekers often choose to pick them up and move them to other places. This is really disruptive when the children have got settled in primary school. I'm wondering if the same happens to asylum seekers and refugees in our area, and that affects the NHS, i.e. they've already settled with a practice somewhere else, and suddenly they get moved to a hotel here, and so you end up having to repeat or start over. It seems to me a horribly unsettling thing that these companies are doing. Is that an issue here?
My experience has mainly been around has only been around the families living in the Bridging Hotel. I don't have experience of those individuals moving into housing locally. I think that we could add that to our list of challenges. Housing, getting people settled and out of a Bridging Hotel. I do know of some of the families who have actually had relatives elsewhere in the country and have moved to new practices in London or the Midlands. And in those circumstances, especially where there have been particular challenges that we've been overcoming, I'm thinking of a family, for example, who had a very young disabled boy due to spina bifida, and he had a wheelchair, and there was a few health issues. We were able to find out where they re-registered, and then had a chat with the GP there to hand over. So those kind of, as with everything, communication is vital. In terms of the process of housing, I couldn't really comment on that effectively, I'm afraid.
And I should just clarify, I meant housing in inverted commas. This is where they're putting them in kind of barracks or all sorts of different places and then just picking them up and moving them again. But no need to go any further. Thank you, Barry.
Thank you, Barry. I've got Sarah Lou online, Sheena and Frank all wanting to ask questions. So, Sarah Lou, can I come to you first?
Yes, thanks, Chair. Barry, I just want to first of all say that I think what you're doing in Exmouth is incredible, and to have a film of somebody feeling so positive about their experience, I think is something that I hope you're very proud of within the community. It's really lovely to see. I'm aware that Sea Change is a voluntary sector organisation, and it's really lovely to see primary care working really, really closely with them. Is that sustainable going forward? Is there funding for Sea Change going forward to support that area? And also, you mentioned the mental health support that's required. Are they managing to actually receive that mental health support, and what does that look like at the moment?
I can't overstate the benefit of having an organisation like Sea Change on board with this sort of effort. They are our eyes and ears and welcoming smiley face for the residents of this hotel, and that close working with them, where they're almost like an outreach part of the service, of all services, really just to be that person on hand. So they were commissioned by Devon County Council to provide that support, as far as I'm aware, and I'm not aware that the funding for that has changed whilst we have a bridging hotel. That's not a discussion I'm part of, but I haven't been made aware that it's changing. We would certainly not be we would be displeased if that were to be the case, because it's such a great service, and they've really built up their learning over the last 12 plus months in terms of how things work best, who to contact in certain situations. They've really been the grease in the machine, and been fantastic. The second part of the question around mental health. So mental health, the access to mental health has been through the existing referral channels, and interestingly, we perhaps made certain assumptions when we heard that refugees were going to be coming, that there was going to be a lot of immediate need for support and around trauma and their experiences. And I think what we found is actually, apart from those individuals who have arrived with a mental health diagnosis, in which case they get picked up very quickly by our local community mental health team, the others, that's why I kind of labored the point of that kind of evergreen offer. It doesn't always come out quickly. And for those individuals, then, because it's not, it isn't a sudden influx of referrals, the mental health team have been able to deal with it quickly. And so by identifying that this is one of the refugee individuals that have arrived and they have these certain, certain set of issues, the mental health team can respond appropriately, as they would for any of our community, really, in terms of prioritizing. So there isn't a kind of fast track or anything like that. We had, we were mindful that all individuals have needs, and so prioritizing the help on offer in proportion to those needs. So far it's been working well, and our mental health team have been happy with how it's gone.
Brilliant. Thanks, Barry.
Thank you. I'm going to come to Sheena and then to Frank. So Sheena.
Thanks, Barry. That was really, really interesting. I've got a kind of question about gender differences in experiences and perhaps the way in which people express their experiences and also access services. And I was also struck with what you were saying about the translation issue and using the telephone. Is there a case of being a bit more imaginative with regard to digital solutions, so that rather than having a sort of telephone, one could have a kind of face-to-face with another woman or a group of women? Is this something that the ICB could facilitate? I'm just kind of very aware of the fact that there will be gender differences in terms of one's ability to perhaps be more public, and in terms of that sense of isolation. Is this a possibility? Is this something that we should be looking at?
Simple answer is yes. I think that's a very good idea. Many of many of these individuals have had access to various bits of IT back at home. They just had to leave it all behind. So they're not necessarily, completely without IT skills by any means at all. Many of them have iPhones and things like that, which they managed to bring. And so I think, yes, I think in terms of, we could be far more imaginative around connectivity, especially in that when it comes to certain languages, for example, that you might find that you're the only family, although you might have a common language with some others, especially if you had some education perhaps, but it may be that your wider family are the only ones who speak that language, and that's happened certainly. And so that's a very good idea in terms of creativity and making those links to our other bridging hotels. I wonder whether that's something that, rather than is kind of done for these individuals, that might be a very nice thing for these individuals to spark off themselves with support, because there might well be certain cultural sensitivities in how those introductions are made and so on, which I certainly would be clumsy with and probably get wrong. So I would value them in steering how that introduction could be made. But very good idea. Yeah, absolutely. I think.
Thank you. I'm going to come to Frank O'Kelly.
Thank you. It's not actually a question, it's just to add to the experience, because we had asylum seekers in Tiverton as well. Barry was incredibly helpful in giving us information, because they had already got the asylum seekers in Exmouth, but we had a slightly different cohort. So we were approached on the Monday and said, we might be sending some asylum seekers to Tiverton. Would you be able to look after any of them? And we were told it probably 2-3 week lead into it. We had 70 people in the hotel by Thursday. They've been processed. It was a slightly different cohort to Barry's in that they were mainly men who'd come across the channel. They're processed for 4 or 5 days. They then get dispersed around the country. So it's quite a lot of hard work to process them, get them registered with the practice and try and sort out all their issues. The community were fantastic. They all got involved. But the real problem was, answering Judy's question, they were all moved on when the owner of the hotel decided that they'd earned the money over the winter and they now wanted to rent it, the hotel over the summer. We found out about it probably 3 weeks before they were not going to be told. We could not know where they were going to be moved on to, and suddenly they were just moved almost overnight. So it takes quite a lot of effort to build a relationship with them. It takes a long time to get them into any NHS services, and just when you're at the process of doing so, somebody decides their money is made and they get moved. So it is quite a challenge, but it's one that I was delighted how the Tiverton community responded, actually, and lots of the local school and people tried to get involved. A lot of the voluntary sector tried to get involved, but of course they sort of put effort into it, and then suddenly the people disappeared.
Thank you very much. I can see that we've got Tracy Lee online, so I'd like to ask a question, and then I think we may need to move on to the next item on our agenda. So thank you, Tracy.
Thanks very much. And it's just an offer, actually. I'm the regional lead for migration, and it might be helpful if I get a note circulated to the board. There are, I think, 5 different schemes for refugees and asylum seekers. Asylum seekers have no recourse to public funds. It's a very, very different arrangement with spot hotels, contingency hotels. And there will be, over the next 12 months, a widening of the asylum seeker system for accommodation in the southwest, along with other places. So some of those issues, it may be helpful if the board is aware of those. I'm quite happy to make sure a note is circulated.
Thank you very much, Tracy. I think we would all appreciate that. And to return to this, if we could put this on the forward planner. I know that Jane Milligan has a note in her Chief Executive's report, and we'll come on to that as well with an opportunity to how we go forward. So I could meet with you separately after the meeting, Tracy, and we could think about what would be the questions and points that you'd like us to have on that going forward. Thank you. And Barry, can I just join all colleagues here in thanking you and all your team for the extraordinary work that both you and Sea Change are doing in this area and for sharing the knowledge and best practice. Thank you very much.
Pleasure.
Thank you. So we were next going to come on to the section with the Chairs and the Chief Executive's report, but Jane Milligan has had to step out temporarily. So I'm going to return to that later and come on to the assurance and system oversight part of the meeting. And we're going to be looking at reducing and mitigating health inequalities in planned care. And I think this is going to be led by John Finn. Do we have John?
Yeah, a very, very good morning. If I can introduce Dr. Claire Hooper, our Strategic Lead for Planned Care, and Dr. Helena Posnet, the Consultant in Public Health. Claire is going to run through the paper very quickly, and the three of us will be available for any questions. Okay, if I hand over to you, Claire.
Thank you, John. This paper is on page 30 of your pack, just for information, and it sets out the health inequalities requirements for elective care, which has been placed on Devon by NHS England for 2022-23. And it details where we are against these requirements, as well as the next steps that we're being asked to take to push the health inequalities agenda forward within planned care. The board is asked to note this paper. So taking this paper as read, I'm just going to quickly run through the contents of the paper. So on page 3, there is an explanation of health inequalities, with page 4 giving evidence of health inequalities specifically within planned care, both pre-pandemic and during recovery. Page 5 of the paper details what the requirements of the operating plan in relation to health inequalities within elective care. And page 7 details our current progress against the work plan as of December 2022, using red, green and amber as a coding. We have an assessment of progress from the trusts on page 10, which was as of November 2022. And it's noted within that UHP have had some external support from Optum and therefore are in a stronger position than other trusts. Page 10, 11 and 12 detail the agreement which has been made following Planned Care Programme Board in November 22. We do note that progress has slipped due to capacity issues, so the decision was made to focus on the November meeting on health inequalities, and we made some agreements following this board. An agreement was made to identify a named person within each trust to have responsibility for the programme of work, and the names have now been received as of this week. There will be an agreement of a setting up of a task and finish group who will be responsible for developing and overseeing the delivery of the work plan, share the learning and monitoring of progress, and that has been in the process of being set up for January, early February. And there's an agreement that the must-dos detailed within this paper will be completed by the end of March. One update on the 3 must-dos. The EHAA is due in the paper said to be completed by the end of December to be fed back in January. I'll take responsibility that this will probably be completed by February and fed back in March. For me, it's really important that it's done properly and that we have a meaningful, smart plan that makes a difference to our population. The publication of remaining trust board papers with view to simple ethnicity and deprivation will be completed by the end of March, but future work will be decided within the task and finish group, and the clinical validation will be brought back to Planned Care Programme Board in January, including the element on the paper with the heart tool and clinical prioritisation. So that's a really quick run through. I'm sure you have some questions, so if I pass back over to yourselves.
Thank you very much for that. Now, I know that Sheena Asthana was keen to ask a question. So, Sheena, could you lead off our discussion on this paper? Thank you.
Yeah, thanks very much for that and for the very clear paper. I've kind of got, I suppose, 2 questions. The first is that there are an awful lot of methodological banana skins that one can kind of slip on in this type of work, depending on what denominators you're using, the kind of quality of the data that you've got in terms of coding, but also whether or not you're controlling for comorbidity. So I suppose the latter point was my main one. Are we controlling for comorbidity in this? Because that might account for differences that we see, which may then not be due to bias, or I think what was the phrase used, clinicians favouring the educated or whatever, but it may well be due to other factors. And I think it's really important to understand, not just to sort of map out. So that's my first question. The second, I think, is a bit of a plea to use the term ethnicity rather than BME, because and I speak as someone who does not see herself as white, but there's always this assumption that of somehow the victimhood of non-white people, which I find really quite offensive, and particularly in the Southwest, where I think the kind of social demographic nature of ethnicity may be quite different to somewhere, say, like Bradford. And I'd be more interested to look at ethnicity with a kind of open view that it may well be that our white working class people are particularly underprivileged in this respect. So it's just a bit of a plea about that. But a related question is that certainly when I was doing work with HES, ethnicity wasn't very well coded. And is that still an issue?
So I think Helen is probably best placed to answer this. Yeah.
Sheena, if it's all right, we work together a lot. Are you all right if I take the second question first? Yeah. So absolutely spot on. We know our ethnicity coding is not as good as we'd like it to be. There's currently some work being led by the Devon Intelligence Function Group, which this work will be receiving support from, to bring a paper together as a bit of a baseline so that we can consider collectively, and there's a broad church here, we've got multiple data sets, actually how we improve data. In my mind, improving data is as much about our working with our staff, our workforce and organisations. So that is one element. And I would also say, I completely agree with you, BAME is not an expression that we use, and we use in Devon ICS. I will absolutely put my hand up. I probably proofread the paper last, so it's in the paper. Then that's me, and that's an absolute oversight. And I've found myself saying similar things actually around that. Going back, I think, to your first point, which was around the methodology, I couldn't agree with you more. And I think for me, I'm absolutely delighted that we're standing up a system-wide group so that we can actually work and have a methodology which has been approved across Devon, builds on the work that UHP has started, and actually can use the expertise that we have within the Devon Intelligence Function Group. So we can say, this is the way we're going to take it, this is the way we're going to do it in Devon. And I also feel that it would be naive for us to think that this was a simple ask. I think it looks very simple, but for anyone who's worked with data and evidence, you're absolutely right, Sheena. It's not just a simple case of saying, run the analysis and present it. The analysis is going to need that interpretation with expertise to understand actually what conditions are we talking about? How do those does the activity compare to the prevalence within the wider population and other things? So for me, I think we're on the start of a journey, bringing people together, ensuring we're linking with our data intelligence experts means we've got a chance to do it right and actually in a way that adds meaning and doesn't just tick a box, and means that we can then take action to then think about how we can then provide support for people and influence our practice moving forwards. So I think both of those are really important points, and thank you for raising.
Thanks. Can I just come back on, because that's really, really, really reassuring, but I still kind of got a slight concern about the resource implications of chasing, say, ethnicity data without, if we have a limited resource, what I'd rather do is kind of chase more granular level data, because I think it's going to be at the most granular level that you start to see geographical variations, and that might be quite interesting. So it depends on what the resource is available to, but the priorities seem to me to be very much set nationally, and they may not reflect our own local kind of issues, such as sort of coastal or very rural, so it's just a case of taking a proportionate and fairly locally informed approach to this. But thanks very much for the reassurance.
Thank you. I'm going to come now to Tandy and then to Steve Brown.
Yeah, just an observation, really. Obviously, you say we still have some data challenges relating to ethnicity and stuff, but I was thinking, just connecting to what we've just discussed relating to refugees, I think even if we were to code them in, we might actually not be able to pick out the issues that are specific to that group. So if you're white and from Ukraine, the issues that are specific to you might not actually come up. Is there any possibility that groups like refugees, for example, can be looked at as a subset, slightly, obviously not as part of the bigger picture, but I think there's definitely value in looking at special groups like that, slightly outside of the ethnicity stuff.
Thank you, Helena. Were you wanting to respond to that point before we...
I can do if we've got time.
Shall I quickly just respond that the EHIA has actually all these groups within it, and we will be really going through each group individually. So refugees, prisoners, coastal. So there will be a focus on individual groups and their specific issues.
And I think, sorry, just to add, I think in some ways the data gives us the first starting point, but the critical next point is then to go work with communities and persons with lived experience to really understand what the nuances are, and then what the work's needed in a way that's appropriate for a particular community. The data won't give us all the answers. We're going to still have to do more.
Thank you. I've got Steve Brown next, and then Sarah Lou and Tracy.
Thanks, Sarah. First of all, just say thanks, Claire and Helena, for surfacing this, and I think excellent paper. While clearly the reds indicate some more work to be done, and I think the action plan and the actions you've described there, Claire, are really helpful. Just a general one, really, in terms of, rather than getting into detail, but the discipline of the equality kind of health impact assessments, that approach, the methodologies. This is obviously clearly looking at planned care, and I guess the question would be for us as a board, and how do we learn from this and shine that same light on other areas of work in terms of the health and care system as well, really. So it was just how do we kind of gather this learning and sort of surface it around other areas which we know are hugely important in terms of inequalities as well.
Did you want to respond to that? Yes.
Oh.
Yes, please.
I can respond as well, or Helena's probably better for gathering the response.
I said on the absolutely. So within the Health Inequalities and Prevention Programme, I've been working with the team, certainly in NHS Devon, who has responsibility for the current equality impact assessment process, to look at how we strengthen elements around, how we describe information around our inclusion groups. And actually, we've got a meeting this week to explore further the vision for that work. And thinking about how we strengthen the learning. So, Steve, I think that's a very timely point. Thank you.
Thank you. And now Sarah Lou and then Tracy.
Yeah, hi. And I think my point probably carries on quite nicely from Steve's. Within this, on the planned care, are we looking at children, young people as well? Yes. And again, yeah, in the learning and moving forward, just thinking it's something that several people have been saying to me is, we really need those data sets across the system to really understand the needs for children, young people. So is that being worked on already?
I can answer that. Yes, for some, historically, when we've looked at elective care, for some we haven't often included children because I think we felt it's dealt with elsewhere. So we want a specific focus working with a specific working group with children. I've got a meeting later on today about it. They've been included in the EHIA as well, because we know obviously children are very easily missed out because they aren't aged, they don't come under that specific thing, but actually can be impacted by education. So yes, I can reassure you that is being taken into account in this work.
Brilliant, thank you. And I'm really pleased to hear the extension into lived experience as well. So thank you very much for that.
Thank you. And Tracy.
Thanks very much. And just again to say thank you ever so much for this paper. This is so fundamental to the way in which we work in terms of our equalities and equality access to services. I absolutely agree with the points around getting the data right. I suppose that in getting the data right, though, that next point around, so what are we actually going to do that makes a difference? So really helpful to hear how that we're going to take that forward. And then just connecting this, I suppose it's much more of a general point, connecting this back to, as an ICS, one of the key areas that we have responsibility for actually is how we impact on the economy. And when we're looking at some of this data and thinking about those more deprived groups, the impact of them being off work for longer, on benefits for longer, not being able to get back to work. Clearly, if we can support and do something to make that change, then that does help the economy for Devon.
Thank you. I'm just thinking if I take Judy's question as well, because time is quite tight. So, and then to respond to those, Judy.
I think that's perfect, because I think my question is quite practical too. So, like colleagues, I think this is a great piece of work. Thank you. And the more information and the deeper understanding we have, the better. I would like to be assured that we're also beginning to look at how we would make changes, because it's no good having a great set of data and then saying what happens on the ground. So if you could tell me, if I were an individual orthopaedic surgeon with a patient in front of me trying to decide to put them on the waiting list for a hip replacement, how would it be different to how it is now? And what work, and I know you can't answer that exactly, but what work are we doing to say, how would we take this concept and principle and make it happen in practice? Because it's only any good if we actually change things on the ground.
And could I just add a further point to that, because it's all on the same theme about what next. One area where we do see significant inequality is people's ability to access private care as part of the pathway, perhaps during diagnostics, and then to come back in. And of course, that isn't an option at all for so many people. How are you within your work factoring that in and the impact of that? But as I say, building on what Judy has said, the interest now will be in what practical steps are you looking at in terms of reducing these inequalities, the what next?
If I can answer about the how, it's a really difficult thing to do, isn't it? There's a balance between when you deal with people on the waiting list, you put people on the waiting list, putting people who came to you first on the waiting list first, but you need to bear in mind that some people have struggled to get on that waiting list, so not everyone comes at an equal point, and therefore there's been quite a lot of work across the country. And the one thing we're looking at the moment is the HEART tool, which is developed by Coventry and Warwickshire in combination with Deloitte, and it's a software that embeds into your waiting list. That can be, there's certain parameters that can be decided locally, age, whether you've attended ED with your condition, whether you have your socioeconomic status, your ethnicity, and it uses that to maybe prioritise certain people. And they've done a lot of work on that. There's a lot of patient feedback, and a paper's has gone out to board members already with some information about that to consider. And so, I think there needs to be something like that takes away the individual person to make that decision. But I guess that's a really difficult decision to make, and I think we will need patient engagement across Devon as to, if we ever do decide on that. But there is the thought of that. At the moment, it's done on clinical priority. That's how it would go on. And when we're changing things around to say, actually, it's not just about taking people in order now, it's taking people in need and taking into account the real person. The second point I'll have to be reminded of, and it may be better that maybe Helena or John answers that.
So I think that referred to the patient's access to private diagnostics as part of their pathway. I think it's really important to understand that in terms of how we're using the independent secondary diagnostics at the moment is to supplement the acute need. So it's not seen as an independent pathway, but whether or not a patient is part of their pathway is seen in an independent provider or in NHS provision, it's still the same pathway. There's no quicker access to diagnostics as part of one pool.
No, I meant in terms of being able to access your operation. If you've seen yourself independently, you've been able to see a specialist.
Yeah, so there are clear rules around that. Yeah. Really clear rules, basically. So that you can't. No, you do. You enter at the same part of the pathway, even though you've seen a private consultant for either first outpatient appointment or diagnostics.
Thank you. I see Frank would like to come in.
It's just in practical terms that doesn't work. What happens is people jump the queue just to get to the first outpatient appointment and then do get transferred back in. So it is something we do need to try and adjust for. The other point I was going to make is Tracy's comment about economic value to the country raises a whole different question about, do you prioritise the working age group to get their operations, to get them back to work if they are genuinely off for a very long time? I think that's even more complex to deal with, but it is possibly something we need to think about.
Hisham, thank you.
Thank you, Chair. So just following on from what colleagues have been discussing, just a request really that when we're looking into inequalities accessing waiting lists, for example, elective care, that there's a particular group that doesn't feature a lot, and these are patients with learning disabilities and those with mental health problems, and they tend to fall at the back of the queue and may not, because of those two areas, access or have a heard voice. And I know that all the groups will be looked at, but they don't feature in the actual paper, which I think is an excellent paper and is very reassuring. Thank you.
Thank you. And I think, Helena, would you like to respond?
Can I come in on that point? Yes. So in our, certainly in relation, some of you may be familiar, but the Health Inequalities and Prevention Steering Group, we have agreed our Devon, priority populations at a system level. They do include patients with learning disabilities, severe mental illness and autism. When we decide how to approach and a discussion is needed at Plan Care Board, we are going to consider the implications for those groups. I know that one ICS in the country made the decision, it was a case study, to look at every patient on a waiting list who was on the learning disability register. That, of course, could be an option for Devon. I think my view is when we're thinking about the prioritisation we want to do, whatever it is, it needs to be agreed, it needs to be acceptable to experts, and it needs to be acceptable and decided with our communities. So I think this is hugely exciting, but I do think we need to do it properly. I think I want to support Claire's point, though, around the prioritisation. That is one element, but for me, an as important element is how we can better understand the needs of those to support people on waiting lists. We have a finite resource. There is elective, activities to address the backlog, but that's not going to happen overnight. So I'm hoping that we can strengthen some of the support we already have in place, working in the voluntary and community sector to take that to the next level. Of course, we're not there yet. We're right sort of at the beginning, and that will all need to be planned and resourced for if that's what we want to do. But this could be the start of something really great. Thank you.
Thank you very much. I'm afraid we are going to have to leave it there because of pressures of time, but that really appreciate the work and look forward to having an update in due course. And I'm sure John Finn will keep us updated as to when we need to bring this back to the board. There's a lot of interest in this area. So thank you very much. I'm going to come on now to the operational pressures, and we have a verbal update from Anthony Fitzgerald. So thank you, Anthony.
Thank you, Chair. As this is a verbal update, I can shrink or expand the time as necessary, but I'll try and be concise. Today's an interesting day. 598 days ago, SWAST moved into what they call their escalation criteria, REAP, black status. Today they have de-escalated into red. That might not seem like a big change, but 598 days of extreme pressure for the ambulance service is, well, I've certainly never known that. So they have de-escalated, and that's partly because of a pretty sizable reduction in attendances over the last few weeks. As people may appreciate, the first couple of weeks in January traditionally is not a good time for the NHS, and I'm not saying that certainly we're in the best place, but certainly in a better place than we would expect to be this time of year. That being said, over the last month or so, we experienced 2 periods of system critical incident. First on the 18th to the 22nd of December, and the second on the 28th to the 3rd of January. And both of those were in response to an increase in Category 2 waiting times. We went beyond 7 hours for that particular category. And obviously that's extreme pressure at our ED departments, but also extreme pressure across the system. We were able to on the basis of that, really test our escalation processes, our system at capacity protocols, and I think it's safe to say that actually there's an awful lot of learning that we can take from that. Although we put in additional cohort in bedding space, we cancelled elective work, we redeployed non-clinical staff, we actually looked at additional triaging of 999 calls, something that we wanted to put in place but weren't able to at the time, but did kick in last week. We also then really looked at what we meant by critical incident across the system and across our provider organisations. And we've made some quite significant changes to that. Firstly, in introducing a clinical criteria. Our chief medical officers and chief nursing officers have been instrumental in revising that. But also looking at what actions we can take in extremis, and there's further work to be done on that, and we're in a process of after-action review of which we will share the sort of feedback and recommendations. Having said that, December also saw some other extreme pressures for us. Industrial actions, both by the Ambulance Trust, but also focused and limited in terms of nursing, but we've still got more to come on that over the next few weeks. We're also then able to look out at, we planned for such periods using the learning that we had from our critical incidents, but also thinking about actually how we can support providers across the system. However, the biggest problem for us actually was around COVID, not necessarily the number of patients who were in hospital, although across our provider organisations that peaked at around 140. It's actually around the impact on our staff, and at one point we had over 800 staff off sick. That may or may not have been one of the driving factors in terms of our critical incident and our inability, firstly, to staff additional areas, but also to staff our main areas and to get patients through the system. Pleased to say those numbers have started to fall again, and actually looking at the modelling that we've produced for the next 6 months, 6 to 9 months, actually the rolling peaks will be hitting us again around February time. So we do need to be very mindful of that. One of the additional problems, though, with a lack of staff is our inability to process patients through the system, and that led to an increase both in our no criteria to reside and a decrease in our number of discharges, particularly across and leading up to those periods of critical incident. Pleased to say that those have started to shift again, but we've got a long way to go to get our discharge numbers back to where they should be. And it isn't just necessarily around no criteria to reside, it's actually our simple discharges as well. The announcement of a discharge fund over the last few days is an interesting one. 4.237 million coming to Devon is a great opportunity, but like all funding, it comes with a number of caveats. It also comes with a huge reporting infrastructure that's required to be able to do that. There will be further information going out to provider organisations today relating to that. We're asking our localities to take the lead, but to work with partners to try and get the best use of that money. And that money's targeted at bedded capacity. and bedded capacity with all of the supporting infrastructure that's necessary. But to spend that by March the 31st is going to be a huge challenge. But, you know, we're up for a challenge, but we'll be able to report back what we've been able to do realistically with that money in the limited time period. As I said, there is a huge reporting infrastructure within that, and we're trying not to invent a bureaucracy to manage that, but to make it as simple as possible for people. But certainly we'll be having some further communications and some information about how that is being spent at the next meeting. The other things really for us are around just making sure that our plans are more coherent than they have been, making sure they're more robust, but also making sure that we are communicating. And I think over our periods of critical incident, our communication across the system was perhaps one of our biggest issues. And certainly we've put some steps in place to try and amend that, to make sure we're using single points of contact within each organisations, and also reminding some of our regional friends that we are using single points of contact across all organisations. That's really all I have to say in this particular slot, but happy to take any questions.
Thank you very much, Anthony, and I'd just like to extend all of our thanks to staff across the entire system who've been working under such extraordinary pressure. So can I open this up to any questions? Frank?
I completely understand the constraints about money coming to Devon and bedded capacity, but as the primary care partner member, I'd just like to raise the issue of this is the third tranche of money this winter that has been labelled as that. The money's gone into the acute sector, and I'm not aware of huge amounts of it going out into the community, which is what actually stops people from needing the beds in the first place. So whatever leeway we have, can we think creatively about how it is actually used and reported? I think part of the crisis in primary care this winter has been because funding that was given last winter was not given this winter. I understand the constraints, but I think I really do need to make that point.
It's a good point, and we're trying to be as creative as possible with what is a very tight set of criteria associated with this funding.
Could I just ask you to clarify, but when you talk about it going into beds, do we mean social care beds as well as, that's what I was assuming?
Bedded capacity in all of its guises.
In all of its guises, so physical beds as opposed to virtual wards.
Basically, the idea is to decompress the system, the acute systems, as much as possible, and that's the impetus behind it.
And is, I'm sure thought is being given to how we're not going to risk destabilising our social care sector.
That has been raised very vehemently by a number of people. But yes, we do have to be mindful of that.
Thank you. Judy, I think you were going to ask a question.
I was just going to say that I felt very hopeful, Frank, when I heard the phrase targeted bedded capacity with the necessary infrastructure, because general practice is part of the necessary infrastructure for these beds that get people out of acute hospital.
Thank you. I think that was more of a comment. Now, I've got lots of people who'd like to come in. So we've got Liz, James, Sheena, and thank you. Yeah, come. So if you'd like to go first, Liz.
Thank you for the report, Anthony, and I would want to start by echoing the comments around our staff across our community and our hospital sector and the considerable efforts that they've put in to sustain services over what has been a very challenging period of time. We often focus very much, don't we, on acute hospitals, but it's really important we also think about the broader community services and how we support our community teams to support people at home and work very closely with primary care. And I think we sometimes miss that in thinking about our focus. The other bit I think we need to also acknowledge is that what we're trying also to balance in the acute sector is protecting the capacity to enable us to deal with the planned care backlogs, and keeping that strong focus and protecting that capacity is equally important to us from an acute provider sector as it is around ensuring that we manage the front door well, because that's going to be critical to achieving targets around 1 or 4 week waits, 78 weeks, etc. Thank you.
Thank you very much. We haven't yet heard from James, Councillor James McInnes yet, so I'm going to come to him first, and then Sheena and Graham Clark in the room would like to come in. So, James.
Thank you, Sarah. You've got plenty of people. I'd just like to firstly emphasise, money like this, it does need to. We heard from our primary care colleague around the table that it does need to go to communities, etc. But the reason I pressed the button was there's a very intense reporting structure. I think the phrase was used. And while I understand the centre wants to know if this money is doing what they want it to do, in the longer term, how do we actually report back that sometimes this really intensive reporting structure, and there's been a number of bits of money that have come down with intense reporting structures, in some ways is counterproductive, and it actually makes people very nervous about what they're doing with money, and it stops innovation. And we really need to find a mechanism of feeding this back to the centre. That I know they want an instant result, and they're very concerned and all the rest of it, but having such an intensive reporting structures put into money all the time is not helpful. Thank you.
Thank you very much, James. Sheena and then Graham.
Slightly related to the point that James has just made, I think there is a danger when you've sort of got a particular fund that you focus on a particular pathway, in this case discharge, whereas actually it's all part and parcel of a bigger system, isn't it? So if we were identifying people with multimorbidities who we thought might be at risk of admission, that's part of it. So the kind of remote consultation is part of it. It's, there's a whole sort of tranche of things. But so it was really, how can we think of this in a sort of system way, which I know that you're all doing because these things are going on. But my actual point was to say that there's clearly some innovative stuff going on. I was looking at Plymouth. They've got the nurse-led remote consultations for people in care homes who may be at risk of admission. You've got the care hotel. There's all these bits and bobs of stuff happening. And my question really is that how are we evaluating this so that we can share learning about what works and what doesn't work? And that's not just about the numbers, it's about the processes as well. What's acceptable, what's not acceptable, what it costs, whether it's cost effective, all of that sort of thing, what the staffing inputs are required. Is that being done as part of all of this? Are we embedding the evaluation and therefore speeding up how we can share the learning?
Right, Anthony.
Yeah, certainly. So, you're quite right in terms of there have been previous tranches of funds. We're using the learning from those processes, firstly, to make this easier for people, secondly, to look at what worked and what didn't work, but also to make sure there's some governance around, heightened governance around this as well, and the money's going to where it's needed. So the localities will be very much taking the lead. But I've had a series of meetings with them already relating to this, because although it was announced, we did get wind that this was coming our way some weeks ago, so they have been able to work those up.
I think it would be much appreciated if you could we could put as an action that you'll feed back to us about the evaluation, because that's been a recurring theme here at the board about how we're evaluating what works. So thank you very much. And Graham.
Thank you. Yes, I'd like to ask about virtual wards. I recall about a year ago people got quite excited about them. There was quite an ambitious NHSE target of how many should be provided for, with incentives to achieve that. I think we'd all recognise it's not a universal solution, but I just wondered whether we felt we were on track on maximising the potential there.
I can respond to that. So we committed to deliver, I think it's 90 plus virtual ward beds in previous schemes. To say we're not on course, and that's because virtual wards, virtual beds require actual staff, and that's been part of our problem. So the delay, so we were due to be going live with a further 50 beds this month. That has now been delayed to next month because of the staffing considerations.
Thank you. Could you confirm for us how many virtual ward beds are currently
At the
open?
moment, 20.
20, right. At a huge cost, yes, thank you. Again, an evaluation of that I think would be helpful too. Right, I think we need to now move on, and thank you very much for that really helpful update, Anthony. So coming on to the Quality and Performance Committee, and Hisham Khalil.
Thank you very much, Chair. And we had our committee meeting on the 4th of January. The highlights, the written report is there for colleagues will have read, is that we continue to see enhancement of the integrated quality and performance report, both in terms of the granularity and quality of the data, the fact that the action plans for where there are concerns or issues are highlighted, and more recently in some areas when the improvement is expected. And as we said in previous board meeting, that's really important so that we can gain assurance, or if not, when contingency planning should come into place if particular actions haven't worked for a period of time. The second bit that we looked into the committee was where we hadn't seen a significant improvement in certain quality and performance indicators, for example, in cancer diagnostics, in elective emergency and urgent care. And again, this will be related to the first item in terms of when we should look into other actions. And there has been some increase in the none and never events, and we discussed that there are robust actions taken by individual providers, but there should be system-wide support, which does exist, and also from region and nationally, and also sharing of experiences across Devon in that particular area. The IQPR again has been enhanced by having primary care data, and that would be further enhanced by having locality specific data so that we can know if there are issues which locality is particularly affected. And the final thing is that our next meeting we are going to dedicate as a development event to look into further approaches when we do deep dives, so that we can refine our approach to those and get the best out of those and get assurance from them. Thank you, Chair.
Thank you, Hisham. Does anyone have any questions for Hisham at this stage? Nope. Thank you. Thank you for that. Could we come on now to the Integrated Quality, Performance and Finance Report? And I think Darren is going to lead on this.
Yeah, thanks, Chair. So the Integrated Quality Performance Report continues to be discussed at length, particularly in the Quality Performance Group, as Hisham has just stated. I suppose a few areas just to draw the wider board's attention to, and it will also link to some of Anthony's comments. So I think for the duration of this report, the CAT 2 response, so this is the Category 2 ambulance response, has remained exceptionally challenging, and that's particularly linked to the time lost of ambulance handovers across the whole of Devon. So I think historically we've talked very focused here around, particularly the challenges are not equitable across Devon, so the south and west challenges are more pronounced, I would say, in terms of those delays compared to north and east. However, for the period of this report, we've seen sort of a significant increase in north and east as well. However, the latest data suggests, and particularly as Anthony's already said in terms of the reposition from the SWAS perspective, the last 2 to 3 weeks has seen a step change in terms of ambulance attendances, footfall. That said, it's still not any easier in our particular ED departments. Our EDs are still under exceptional pressure, and particularly length of stay within the emergency departments remains exceptionally high, days for many of those particular individuals. However, I think, we do need to note that there has been an improvement, but ultimately that is an improvement particularly linked to probably demand on ambulances rather than demand on our ED departments. And I'm sure that will play through in terms of the data over the next couple of months. So that's an area I'm sure that we will focus on, definitely an area that we'll focus on from a quality perspective. Moving on then, so we have seen an improvement and a continued and sustained improvement in our no criteria to result. I don't like that particular term, but ultimately that's the national term in terms of individuals who are medically fit for discharge. And I think that is a good news story, because ultimately that is around more individuals are able to get to their own homes or their preferred place of residence quicker from the point of being medically fit for discharge. However, What we have seen, and I think this is linked to our acuity and complexity, is the length of stay in hospital has increased. So that what you would normally expect for, as we've seen, percentage reductions in no criteria to reside, which see our, potentially our delays in ambulance delays and handovers reduce. In correlation with that, we haven't. But what we have seen is actually an increase in our length of stay, which again I think is a real symptom of an area that we need to understand and learn going forward from a winter perspective, because actually this does link to the acuity and complexity of individuals that are presented to the front door and need longer in hospital. So that then changes our modelling, particularly around the number of bed days and then potentially number of beds. So that's an area to focus on. In terms of elective care, what we have seen is that our referral to treatment time has improved. We are not on plan with trajectory, but we are continuing to see an improvement in those particular areas. However, with the 2-week waits, and particularly cancer diagnostics, we are not seeing any improvement. That's very much a static position at the moment. However, what we have seen is, again, a significant increase in referrals. So again, what we're seeing is that we are able to see more individuals, but actually they're basically keeping in line with the referral rate rather than being able to address and get closer to those 2-week targets. I think it's, it would be remiss to say that primary care has been exceptionally challenged during this particular period as well, particularly access, and that's despite increases in and positive increases in appointment availability, on the day availability, access within 2 weeks, which are again some of the number national targets. So, primary care are working exceptionally hard at increasing capacity, but again, what we're seeing is the demand is still continuing to outstrip, and that is again, the workforce comments that Anthony's alluded to is exactly the same. None of our services are immune to those. 111. So again, what we've seen, particularly in 111, improvements, continued and sustained improvements in abandonment rates, call rates, and quicker answering, despite the ongoing pressures. And again, as Anthony alluded to, some of this data here links to the weekends where we declared system critical incidents. But ultimately, what we've seen is a sustained, improved position compared to where we were a year ago. Again, significant improvements are needed to be made, but definitely an improved position. In terms of mental health, I think what we've seen, unfortunately, some deterioration in some of our main markers, so particularly around eating disorders, access, and access to dementia referrals have increased in terms of those particular challenges, and we know that we're focusing in the meeting after next from the quality group point of view around the eating disorders pathways, and we've also got a system summit coming up in that particular space. However, what we have seen is this sustained and continued improvement around the physical health checks within mental health, so that is as a positive area. A couple of others just to note, and then I'll open for any particular comments or questions, is infection prevention control has been exceptionally challenging during this period. So again, Anthony alluded to our high numbers of particularly COVID, both in terms of inpatients, but more importantly, particularly within our staff groups, both across health and social care. I think it's fair to note that actually that we talk about COVID, the same numbers and the same pressures were around influenza A as well. So when we talked about 140 inpatients with COVID, we were seeing exactly the same numbers with influenza A. And I think what we've seen this winter is that influenza A has been very impactful. It has made individuals exceptionally unwell, both in terms of again COVID for staff absences. What we're seeing is a 5-day absence. I would say for influenza A, we were seeing a prolonged absence, but equally in terms of the acuity and admission rates for flu are significant. And we've also seen the seasonal areas around norovirus, but we are also starting to see some increases in particularly some of our other infection control criteria, particularly around Clostridium difficile, which is again a national position, but an area that we need to understand. In terms of harm and quality, we are doing a focused area around improvements around falls, because we are seeing that one of our main high areas for serious incident reviews is around falls within our inpatient setting, so an area that we're looking as a system to improve. And interesting, despite the challenges, we have seen a reduction in our contacts around patient complaints and patient device liaison. So that's an area that we are, again, looking at and understanding. And then probably one other area in terms of safeguarding. So what we are seeing, particularly a significant increase in terms of Section 42. So again, appropriate safeguarding intervention to understand support providers. So those numbers remain as we would expect in terms of regulation, in terms of those safeguarding reviews. However, within that, 70% of those are now flagged around quality of care, whereas that was about 40% 6 months ago. So again, an area that we need to support and focus, and that's across the whole system. And those are probably the headlines I want to flag, Chair, but happy to take any other comments or questions.
Thank you. Does anyone have any questions? Judy?
It's not a question of Darren, it's a linking us back to the point that Graham made, if I could. On page 68 of the board papers is the winter demand and capacity programme, and that's where the figures on virtual wards are listed. And I'm assuming, Liz, it's your team that's opened the 20 beds in January. We did discuss this at the quality and performance review. And my concern is, so I just want to mention to the whole board, that it is often when we get funding for institution-based services and community-based services that it takes so much longer to get the community-based ones going. And that bothers me. Virtual wards are not a new concept. They were running as hospital at home back in the 90s. It's not massively difficult. You need district nursing staff and appropriately trained people with supportive GPs and things. But it just bothers me that, and I've seen this in other reports, so you may think I'm over-egging it on this, but I would really, and Liz just raised now, it's as important that community services are supported as primary care. And maybe it's not for discussion now, but could we have a bit of a robust think about why it is that, I remember during COVID when we were talking about therapy services, all the community therapists were pulled into the hospitals. You know, just could we have a proper discussion around ensuring that community gets as much focus as institution-based, and what would help with that?
Okay, well, I'll put that as an action point for us to give some consideration to how we best bring that back. So thank you. Does anyone else have any questions for Frank? No.
It's just about the ambulance reporting. I get a sense that we know what the problem is, but we don't know what their productivity is. I don't know how many people an ambulance crew see in a shift, and I can't get that from this information. Others might know it. There is an assumption that having low transfer rate at 38% is a really, really good thing, and yet we end up having an ambulance service that has the worst figures in the country. So I'd quite like to know, rather than concentrating on the delays of a handover, what their productivity is within their working service. So, you know, a crew in an ambulance, how many patients do they see per day? The reason I ask the question is, about 2 months ago, I had a patient left at home after 4 hours of attendance by that ambulance crew, which I'm not quite sure what they did, because they hadn't actually communicated with me. There was eventually a message left. And 4 hours to leave someone at home is a very, very long time.
I presume this is around our see and treat, but I'll ask Darren to respond to that.
Yeah, and I think it's an area, Frank, that we absolutely do need to understand a bit more around. And I think there's two sides to this. So I think, you know, as an ambulance trust, you know, we talk a lot and we hear a lot about the hear and treat and the see and treat, and then obviously then the conveyance rates. And I think, you know, what we see at the moment is, you know, that ambulance crews work exceptionally hard, you know, to try and prevent admission. And I think, you know, is again, how do we work as an integrated care system around making sure our directory of services is right, so that actually the communications are happening, so everyone's aware that this individual has sought help, and actually how we then, you know, is that the right service? And I think some of the work that we're doing at the moment around monitoring the call stack and taking individuals out of the call stack to actually make sure that the ambulance service are responding to the most appropriate individuals. I think it's a really difficult one to measure at the moment, because actually normally when you talk to our South West Ambulance Service Trust colleagues here, they talk about a paramedic crew attending 4, 5, maybe 6, depending on reality, calls a day. And that will be a mix of individuals that they will see and treat at home, and obviously will convey. What we're hearing at the moment, because ultimately our handover delays are so significant, that productivity has reduced significantly. So, I talk to paramedic crews who potentially will start the shift, picking up, meeting their vehicle at the A&E department, and then they'll spend the entire day looking after that individual in the back of an ambulance and then leaving the shift. Or potentially will respond to one, maybe 2 999 calls in a day. Ultimately, that is a massive productivity issue that we as a system need to support and need to understand. Equally for those individuals, there's a wider legacy skills issue there, because actually these individuals who potentially were responding 4 or 5 calls a day are now looking after one individual and looking after that individual exceptionally well, but that is not their training. So I think this is an area that we probably do need to explore, and I think probably, not speaking on behalf of the chair of the quality group, but Hisham, this is an area, as we talk about urgent care and future elements, we need to understand actually how as a system we can support that productivity, because actually there is a skills derogation or degradation issue that we need to understand as well.
Thank you. Now I'm conscious we're really over time now, so can I ask, if we've got Sarah Lou and Sheena, can you keep your questions really brief, please, or comments? Sarah Lou.
Yeah, Darren, can I just ask you, the length of stay, the increased length of stay, do those people need, is it the right place for them to be on the ward, or are they potentially people that, for example, if we had cottage hospitals still, could be going into the community where they would be supported? So is there something around virtual wards, increasing community capacity to move some of those people out sooner of the hospital, or do they need to be on the hospital wards?
I'm going to take both questions. So Sheena, could you ask yours as well, and then and Hisham as well. So
it's not an easy question, it's a comment. I read this and it's a quality report, and yet I'm not getting much of a sense of quality. I'm getting a sense of externally imposed targets, and it doesn't give me any sense of the experience that people will be having. I mean, you alluded to the 4-hour wait. It worries me for 2 reasons, and I feel that when I look at these figures and then I hear, particularly on the mental health side, some of the experiences of services, I find it really hard to join these 2 things up. This dry stuff against the appalling stories that I'm occasionally hearing. But the second is I'm worried that it takes us away from focusing on what might be better solutions. So actually you can really improve people's quality of life if they're on a waiting list by providing mental health support, prehab, say they're on an orthopaedic waiting list, getting them fitter, helping them lose weight, helping them with their mental health. That can actually be a quality improvement. But because we're so focused on these flipping statistics, we don't, I hope we're doing this, but I don't know. So I don't feel I'm capable of commenting on quality from that point of view. And similarly, it was a comment, I know I shouldn't be putting comments in the box, but the whole emphasis on discharge is preventing us from actually perhaps looking at the more cost-effective and more effective prevention of admission. So there's a whole load of things here that I'm worried about, the sort of slightly perverse incentive of this reporting mechanism, and kind of want a bit more about quality. And finally, on that, I do feel in a digital age we could be collecting some more information from patients which don't involve the kind of old forms, particularly our younger people who are perfectly capable of doing great web-based stuff.
That's really helpful. Thank you very much. Darren, did you want to comment on that, and then I'll bring Hisham and Liz in?
Yeah, more than happy to. So first of all, Sarah Lou, so I think very much where we are at the moment, I would argue that potentially the number of individuals that historically would have sat in our community hospitals are currently being supported by our nursing homes. The level of complexity and acuity has definitely shifted in that way. I think it is definitely a symptom of the complexity of individuals who are being admitted to hospital that do need that little bit extra time. And it's about, on average, just less than a day, but less than a day over whatever it is, the bed base of Devon, 2,500 hospital beds, is a big number in terms of that criteria. I think one of the other elements is almost certainly linked to the element of capacity and individuals having to be supported in a hospital bed, maybe not in their specialty. So then again about the medical reviews and those elements. So I think there are 2 sides to that, rather than actually this is a symptom of the community hospital capacity. and again, I think, Sheena, your comment, I think absolutely, I think, the area that we are working with, and particularly with Andrew's team, and particularly with Health Watch, is that we need to triangulate this with we've got the quantitative, but actually we need to understand the qualitative, because actually, all of these metrics, they're not, but all these metrics could be, within target, but actually we still may not be delivering a quality service. So I think, absolutely, I've not been able to see a system nationally that's been able to really got this nailed, and I'm very much in that. Let's pinch or work on pride with those particular areas. But it's certainly an aspiration of mine that we need to understand the qualitative and the quantitative, because we need to triangulate that.
So Hisham and Liz, if you could just make your questions brief as well, that would be helpful.
It's really just following from what Sheena and Darren mentioned, in that in the Quality Performance Committee, we look into proxy quality indicators. In the case of the ambulance, what was the outcome of an ambulance crew visiting a patient in their home? And did that prevent an admission or not? And the patient experience. We don't have that data now, but we need to agree with providers on proxy quality measures, and not just the performance bit, which is the response time. Thank you.
Thank you, Hisham. Liz.
I'll be brief. I think there's a bit of a so what test for me. So when we look at the weights, how are we assuring ourselves, and what information are we looking at that understands better the harms that as a consequence of that? Second point, in relation to community data, I know there's a national focus very much on these, but if the way in which we are going to be successful in the acute sector is very much about delivering high quality community services, we need to be measuring more of that so that we can make sure that we're getting the very best out of it, not wanting to make it such a huge report. And then thirdly, just looking at some of the data points in relation to long waits for planned care, there are some themes, aren't they, emerging in terms of some fragile services and the action we're taking to ensure that we're addressing that fragility as a system.
Thank you. And can I just add one other quick question to this? That's been raised with me is, are we keeping an eye on readmission rates as we quite rightly push to get people out of hospital as quickly as possible? A councillor has raised with me whether or not we're seeing a corresponding rise in the revolving door.
So I'll keep my response brief, because I think, Hisham and I think, Liz, your comments were probably more statements, and definitely an area that we need to look at. I think it definitely in terms of the fragile services and particularly the wider work there. But I think in terms of the readmission rate, absolutely it's an area that we monitor. Interesting, it's not an area that we have seen increase in recent months. But equally, again, that's not an area that not to say that the position in the first place was best in class. So again, we need to understand around what are the reasons for readmission. Actually, is it because of need for further medical treatment, or is it failure of package of care? There are a number of reasons behind that, but it's an area that we monitor. And again, I think it's an area of we could probably as before, we've had a 120-page document here, and it's about making sure that we as an ICB focus on the right measures for us. And I think as we see this report continue to evolve, the challenges are potentially, this is a report that probably was very much focused, and very much the work we're doing in the national team around the assurances from a CCG, from a commissioning point of view. I think we need to focus much more about actually what is the purpose of an ICB, and make sure our metrics challenge and check us in those areas as well.
Thank you very much. Well, I think we do now need to move on, but thank you for that. I'm going to come to the Finance Committee January meeting verbal update, and Kevin Orford. Thank you, Kevin.
Thank you, Sarah. Sorry that this is a verbal report, but the Finance Committee was last Wednesday, the 11th of January, so we didn't have time to do a written report. We were joined in the committee meeting by the Regional Director of Operational Finance, and he was there particularly because he was interested in the committee's scrutiny of the revised financial forecast, which Bill will be presenting later on the agenda. I'm going to highlight three items from the meeting, just because of the time constraints we've got at the moment. The first one is the reforecast of the financial position. So just in terms of assurance to the board, the committee scrutinised that revised forecast, and we took particular note of all of the immense work actually that's been undertaken across all the Devon NHS organisations to minimise the extent of the year-end deficit, and we noted that included a peer review exercise. We also received detailed assurances that the forecast as set won't deteriorate any further between now and the year end, and each of the 3 NHS organisations which will be in deficit, they've all signed to confirm compliance with the NHS England reforecasting protocol. All of that's in Bill's paper, which he'll be presenting shortly. Second item to highlight to you, under our delegated authority, we approved a system business case for support to the system to help us to ensure that into the future we can meet the requirements of the NHS financial framework, whilst also ensuring that we can meet our ambitions for access to high quality services, and that we do that in a system-led way. And finally, we discussed the process and the timescale for the development and agreement of the operational plan for 23-24, and took assurances relating to the progress of that. So that's all I've got to report, but happy to answer any questions in relation to the papers which Bill's about to present to us.
Thank you very much, Kevin. What I'm thinking, because time is short, would you be happy for us to combine questions at the end of Bill's presentation as well? So there might be questions for either of you then.
Yeah,
Thank
absolutely.
you. Thank you very much.
Yeah.
So I'm going to come on now to the finance reports and Bill Schultz. Thank you.
Thank you, Chair. What I'd like to do with the board's approval is take the month 8 finance reports as read. What you will see here, and I think it's just a factor of when the board meets, is that the financial information that's presented for month 8 is different from the reforecast information, which is month 9. So that's just because of a timing difference there. And as the Finance Committee Chair said, the Finance Committee met later in the month to allow us to accommodate the reforecast, which is now coming to the board. I don't think it'll be any surprise for board members, given the discussion that we had last month, that the position has deteriorated from the planned position that was signed off at the commencement of this year. To remind everyone, that was an £18.2 million deficit, and that deficit resided solely within the RDUH Foundation Trust. Since that time, as we have reported, and as has been reported to the board through the course of the year, the position in other organisations, namely 2 of the acute providers, has deteriorated, and that's why there is now a significant risk which has materialised and which requires us to reforecast the financial position. There's a detailed paper that covers the reforecast. Finance Committee Chair has referred to that, and I'll go through that in a bit more detail. One thing I would like to point out to the board is this is a significant movement and not one which is in a favourable sense at all. What we are showing here is a new reforecast position with a deterioration from the plan of £18.2 million to £49.5 million. Now, that is slightly different from the position that was presented last month in the private session of the board, and the reason for that is that we have received some additional monies from Region, and we are required to report those monies, and that changes the position to one of a £49.5 million deficit. That is an adverse movement of £31.3 million. In order for us to achieve that position, the ICB will now move from a break-even position to report a surplus of £4.635 million. And that then allows us to have those different movements within the system, the 3 deficits being offset by the surplus within the ICB. Devon Partnership Trust remains forecasting to produce a break-even position. As Kevin said, regional finance colleagues have been fully engaged in the process. The process is one where each of the finance directors in organisations and their team has undertaken a detailed reforecast. That has been signed off by the Finance Committee Chair, the Chief Executive and the Chief Finance Officer of each of those organisations. The reasons for the deterioration are shown in the paper, and that shows the position across each of those organisations that I've referred to. So, as I've said, £18.263 million being the original forecast deficit for RDUH, and that continues to be the case, and then a deficit position in UHP of £17.25 million, and a deficit position in Torbay and South Devon of £18.622 million, break even in Devon Partnership Trust, and that was the £52 million that was originally forecast, and as I've said, that's moved out slightly with a higher surplus now being recorded in the ICB. The reason for These movements, I think, have been well rehearsed, but just to remind the board, shortfall in CIP delivery across all organisations of £31.3 million, and this is a significant issue and one that really does need to be addressed, certainly the remainder of this year, but going into the next fiscal year. As we look at the position for next year, we know that CIP delivery will be absolutely critical. We've seen increased inflationary costs of £7.3 million. We've got a number of other issues which are highlighted here, but I think the one for me that is really significant, as I've said, is the CIP delivery. We can focus on those areas that we didn't understand or we didn't expect to occur at the commencement of the fiscal year, and we can look at the ways that they've been covered off in terms of non-recurring monies, and that's the other mitigations of £18.6 million. But fundamentally, one of the reasons that we continue to have significant financial issues in this health system is our inability to deliver CIP in any meaningful way, and then the requirement to do that non-recurrently and to back that off with disinvestment in services or slippage in some of the funding that we've received. In terms of the organisational positions and the NHS executive protocol, and just for completeness, the Finance Committee received a financial recovery progress report on the 9th of November, and that detailed the action plan which was taken at both a system and organisational level to secure the then financial forecast position for reporting in month 9. So we have been looking at this position for some time. In discussion with Region, it was felt that the optimal time to change the forecast is month 9. So the board understands any change in a forecast position or any deterioration from month 9 is seen as a further failure in the ability of both individual organisations and the system to forecast and deliver their financial position. The position has been continually monitored through the operational planning and oversight group. So as part of the planning process for the current fiscal year, OPOG has the oversight of that, and we have just changed the reporting mechanism to escalate that to the Executive Finance and Performance Group, which is now meeting on a weekly basis, and that is doing two things. It continues to monitor the position in the current fiscal year, and it's also taking the oversight in terms of the plan that needs to be developed for the coming fiscal year to ensure that there's completeness and that there's continuity between the two positions. In terms of the requirement for organisations to evidence the changes, both in terms of their Finance Committee and board documents, the agreed planned position for the RDUH is the one that is now being subjected to the protocol, and that has been signed off. At UHP, the original plan was break-even, and the proposed change in forecast is moving that to a £17.25 million deficit. And Torbay and South Devon, again for completeness, the original plan was break-even, and the proposed change in forecast moves this to £18.622 million. As part of changing the forecast at month 9, the following actions have been required and they have been undertaken. As I've said, signed protocols from boards and finance committees confirming compliance, a report to NHS Executive to support the change in forecast, and the South West Regional Finance Team have confirmed that the report to the Finance Committee fulfils that action, and that was confirmed in the meeting as well. And also, Regional Finance colleagues invited to attend the Finance Committee as the Chair has reported in terms of completeness. It's really important that the position does not deteriorate further, and that revised position of £49.5 million still has further risk. I don't want to alarm the committee because we have been through a very, very detailed process. Each of the CFOs has signed this off, and as I've said, the protocol requires very detailed sign-off. But we have a number of months now until the end of the fiscal year, and so with those risks, it's really critical that the diligence that has been applied to move the forecast position out is also now something that ensures that that is the position that we deliver, and that is the maximum allowable position. The position can move favourably against that, but that is a position that cannot be breached, and that is one of the key issues in terms of the protocol and the requirement that we've had. Managing those risks through the final quarter will be done through a liaison with operational colleagues, and we will continue to assess the impact of winter pressures and the impact that they will have on both service delivery and, as a consequence of that, the financial position. Executive oversight of the position will continue at organisational levels within each of the organisations. CFOs continue to meet weekly with myself and with my team, and where there's any known variance to forecast, that will be reviewed and mitigations will be sought immediately. As I mentioned, the Executive Finance and Performance Group has had its meeting frequency changed from monthly to weekly, and membership has been expanded to include CEOs, CFOs and COOs, and also to ensure that there's workforce representation as necessary. And that enables us to swiftly respond to any intelligence received in terms of workforce, activity, performance and finance. The monthly risks and mitigations process will continue as part of a monthly financial reporting process to the ICB Finance Committee, so we'll continue to report this position between now and the end of the fiscal year. And so as a consequence of that, formally, the ICB board is being requested to note the change in ICB and system forecasts at month 9 to £4.635 million surplus for the ICB and £49.5 million forecast deficit for the Devon system. And this was approved by the Finance Committee on the 11th of January 2023. And to note the need for ongoing management of the system financial position throughout the remainder of Q4. At that point, Chair, I'm happy to take any questions or deal with any issues that are not clear for board members.
Thank you very much, Bill. Clearly a really concerning situation. Can I open this up to members for any comments or questions at this point? I know there has been a detailed discussion in the Finance Committee already, but for any colleagues who weren't able to be there, are there any points or questions? No. Judy.
Bill, thank you very much for the very clear way you report things to us. It's really helpful. I want to understand your level of confidence that we can keep this under control for the next 3 months. I can't decide whether that's an unfair question or not, but I think what I would like to know is, do you think everybody's got the message and we can keep within what our now stated overspend will be?
Thank you. I think the CFOs have most definitely got the message, and I think through the discussion and the agreement with the protocol that they have briefed their boards and executive teams and finance committees appropriately, and that those organisations have signed that position off. So I am very confident that the position that I have just gone through will be the position that is delivered. There is some contingency within that position. My preference would be that organisations deliver what they've now undertaken to deliver, and that any contingency is something that's available to us in a future financial period.
Thank you. I'm going to bring Tracy in.
Thanks very much, and thanks, Bill, for the clarity from your presentation there. It might not be a question for you, Bill. It might be a question more widely. But I suppose one of the things that's really important is that matching of the financial position to what won't happen or what will happen in a different way as a result of that financial position. So as a board, our oversight and understanding of any strategic changes as a result of the financial position, I think would be incredibly helpful. Or Bill, you may just say actually everyone is just battening down the hatches and there are no significant variations to what services are currently provided.
I mean, I can have a go in the first instance, and if colleagues want to add to that. I think in the current fiscal year, I don't see that this is something that impacts on the strategy or the investments that have been undertaken. And in fact, one of the reasons that we have the problem that we do is we've spent too much money. So we've actually spent more than we have undertaking those investment decisions, those strategic decisions. Where this will become really challenging is when we move into the next fiscal year and we have to review those things that we've done, and we have to take the difficult decisions about investment, disinvestment, reprioritisation. That's where I believe it will become really difficult. In this fiscal year, the monies that we've been receiving, so the discussions that we've had previously in terms of Better Care Fund, in terms of the discharge funding, the expectation and the assumption is that those monies will be spent in this fiscal year. it's next fiscal year and the year after that, when the funding settlement becomes even more challenging, that I believe we will have the really tough decisions to make.
Thank you very much. I know we'll be returning to this. So I'm just conscious that we've been going now for a long time. We're nearly at the end of this part of the board. Are colleagues happy for us to just continue for now rather than take a break? Right, lovely. So I'm going to come on to the governance.
Sorry, Chair, just for completeness, did we agree the recommendations?
Okay, yes, I thought it was for noting, but we're agreeing the recommendations. Yes, thank you. Thank you. So we're going to come on now to the governance and risk section and onto the Audit and Risk Committee December meeting update with Graham.
Thank you. So, in fact, there is no update in terms of the committee. We've decided to move to 6 meetings a year rather than once a month. And I know that's still pending the governance review in any case. So no committee to report. But there was a paper from the last one that wasn't in the previous pack. Just a couple of things to note. One is I flagged last time that there was a proposal for a risk workshop with the chairs of the audit and risk committees, and that is still in planning phase, but we will be undertaking that. And the second is an update on the external audit position, which, Bill, I think you can probably helpfully fill in a bit more of the good news.
Yes, thank you. So it's still work in progress, but I've had detailed discussion with Region, and as a consequence of that, I've also spoken to an audit provider. My expectation is that following correspondence with the audit partner, that they will change their position and they will agree to be the auditor for both the 3-month period of the CCG and also the 9-month period for the ICB, and then look to be the audit provider for the year after this. That is one of the big 4 accountancy firms, and I've been able to get them to change their position in terms of Devon as an audit target. I will obviously liaise with the audit committee chair, and we're looking at the fee requirement for that. The board should be apprised of, and the audit committee chair has already been apprised of the fact there will be a significant increase in this audit fee, and we knew that was something that was likely to happen. And the second point, subject to agreement of NHSE nationally, which we expect to get, we will appoint this audit provider, but also we'll be doing that in the knowledge that the audit will be undertaken for completion in August rather than the June deadline. So we'll miss the deadline by 3 months, but we will have an audit in place. I'll clearly update the audit committee as I get more information and I'm in a position to release that, and the board will also be updated as that occurs.
Thank you very much. And I know on the item around board assurance framework, we're going to have a further discussion with that in our private session, and that will then come back to the full board for approval. And I know there are no updates from the Primary Care Transition Committee, and Kate Shields' report, Cornwall and Isles of Scilly board update, I'm going to take as read. And then finally, because Jane has now rejoined us, it was just to ask if anybody has any questions relating to either the chair's or the chief executive's report, because if not, we will note them as taken as read. Thank you very much. So that brings us next on to the action log. And item 3 on the action log, we've now been able to all see Dr. Hooper's excellent report. So I'm going to request that we close that. And then we have 2 items that are still in progress, one of which was item 24, which is led by Darren. Do you want to say any comments on that, Darren?
Yeah, so we've had a response from the trust, and I'm just getting the final completion to make sure that that has been communicated with the individual, and then we can go back and follow up.
Yes, because I think I'd committed to follow up with him as well. So thank you. We'll keep that one in progress. Yes. And Graham, you've already updated us on the other items, so that remains there. Thank you. Right. Well, I think we have no questions from the public. So is there any other business? No, Frank.
I'm just not quite certain where we are on the Cavell Centre now, because I believe the end of the year was going to be a sort of time-limited value or cost, whether we actually have no options at this point. But clearly there are practices in Plymouth that are not in a good place.
Okay. I think, Jane, do you want to comment on that, or perhaps to commit to bring that back to a future session?
I can see Joe's got a hand up, but probably just need to be mindful. This is a moving feast, isn't it, Joe? And Tracy, I know, is busy working behind the scenes too, but just a brief update would be great, Joe.
Yeah, I will keep it very brief. So firstly, I just want to thank Tracy again for her support in this regard. And in fact, there is a meeting tomorrow with the Minister, so Lord Markham, which Tracy will be attending with the leader, and we've had a pre-meet for that, so that was a really helpful conversation. So thank you as well, Sarah, for your input. So as you say, Jane, this is a moving feast, so we have got a conversation tomorrow. Just for assurances, though, we do continue to work with our partners in primary care to understand what this means for them, and if there is a delay with the Cavell Centre, or we will, or we are already working on plans for them in case there is a delay, or indeed for some reason we can't move that as quickly as we might have wanted to. So just give you those assurances, Frank.
Well, thank you very much. That brings us to the end of our board meeting. So thank you, colleagues, for your contributions today. Much appreciated. Thank you.